On this December day, I welcome you at our 12th and last this year webinar of the Virtual Medical Consilium within the operational research on modified shorter treatment regimens for the treatment of drug-resistant TB. My name is Dr. Elmira Berikova. I'm the coordinator of the Virtual Medical Consilium, and our today's topic is drug-resistant TB with concomitant renal failure. But before we proceed to the agenda and to the topic of today's webinar, I would like to give the floor to Askar Yedilbayev and Askar Korotych, who represent the TB team of the joint TB HIV hepatitis program of the WHO Europe. Askar, please, the floor is yours. Thank you, Elmira. Dear colleagues, please let me welcome all of you here at our 12th webinar of the Virtual Medical Consilium of the WHO Europe, dedicated to a very important issues. So we are going to touch upon topical things. We hope that today's webinar, and especially the introductory part, will help to deepen the understanding of the importance of switching to fully oral treatment,
что укрепит нашу уверенность в правильном подходе и
to help us choose and use a better, proper approach to the treatment of drug-resistant TB, which is confirmed by the operational research on modified shorter treatment regimens. Without further ado, I would like to give the floor to our next speaker, wishing you all the best, good health, and a very successful webinar. Good day, dear colleagues. Let me also welcome you here at today's webinar and present very briefly the progress of the implementation of fully oral shorter treatment regimens in the region. As you see, we have reached the middle part. 8 countries have completed the rolling of the patients, and the future steps will include completion of rolling out in the rest of the countries and continuation of treatment of patients who have been enrolled, and 12 months follow-up for each of the patients to identify the final outcome, whether the treatment was successful or not. Our initiative, the initiative of WHO Europe, is to go further. We won't be complacent. We want the countries to continue patients enrollment within country cohort, to scale up knowledge about shorter, fully oral treatment regimens, to treat patients with really successful treatment regimens within operational research, because they are not yet recommended for programmatic use. As for the regional cohort, we have more than 2,500 patients enrolled. You see, Ukraine and other countries have made huge contribution to the work with the patients, to patients enrollment, to treatment. We perform quarterly monitoring missions, and within these missions, we want to stress that important aspect of this regional project is quality data collection, especially given the fact that the majority of countries have completed rolling patients, and the completion of forms, the enrollment forms and microbiology forms should be filled in for all patients so that we can perform the analysis of the database with consecutive follow-up analysis to be performed next year to come to the final outcomes. We thank you for your active work, for your active contribution. You see that this work is being performed actively in all the countries, and you see the 5 leading countries in this area. We are going to continue supporting all of you. Thank you, Askar. Thank you, Alex. Before I introduce our first speaker, I would like to very briefly remind the participants to keep the microphones switched off. If you want to ask a question, please use chat we will be monitoring all the questions. We will read them out. At the end of the webinar, we will dedicate the final 15 minutes to Q&A session. Our first speaker of today, Dr. Michel Rich. I think that many of you know him or at least have heard of him because he has published a lot of articles dedicated to shorter treatment regimens. Dr. Michel Rich is the PhD and associate professor of the Harvard Medical School, and he also represents Partners in Health, and he is a co-researcher in MTB trial. Unfortunately, Michel Rich, because of the time difference, is not able to participate online, but he has provided his audio recording, and all the questions you might have to Michel, we will be glad to forward to him so that he can answer in writing, and we will circulate all the answers. Alex, please. Dear colleagues, before we switch on the recording, we would like to ask you to switch to Russian channel because it will be interpreted into Russian. The original is in English.
Hello, everyone. I'm Michel Rich, and I want to thank everyone for inviting me to be part of this webinar on the drug-resistant TB and the management of kidney failures. I'm very sorry I can't be there with you live, but I did put my email at the end of my presentation, and I invite you to ask any questions and send an email to me if there are questions, and I hope there's some lively discussion after my presentation. So without further ado, we'll get the presentation up there and start the webinar. So my presentation will be on providing some review and evidence of what is the role of injectable agents going forward in the management of MDRTB. We know that injectable agents are the #1 cause of renal failure in MDRTB patients as a result of the toxicity to the kidney. And WHO have come out with recent guidelines of how where these injectable agents should fall in the prioritization of the medicines. So we're going to, in this lecture, we're going to talk about the role in the injectable, and then we're going to talk a little bit about are all oral regimens based on the group A drug and group A drugs of tuberculosis treatment sufficient to use, and is there evidence that shows that we really don't need to use the injectable in most patients, and therefore sparing them a considerable amount of toxicity, both for renal toxicity and for hearing loss. And then we'll give a little bit of evidence that, or just a little bit of dosing. We still see a lot of patients with renal problems, and we'll give a little bit of some dosing recommendations on how you need to adjust the TB medicines, and especially the new ones, which some of you may not be as familiar with adjusting when you have severe renal failure. So I'll begin with just a little recent history on the WHO recommendations around the injectable agent. And really prior to 2018, the guidelines recommended that an aminoglycoside, or like amikacin or kanamycin, or a polypeptide like caprimycin be administered parenterally as part of the treatment. They were very high in the hierarchy prior to 2018. After 2018, beginning in 2019, they found evidence that they were not associated with good outcomes, both in terms of success rate in treatment. And, prioritizing high in the hierarchy meant that most patients were subjected to very painful daily injections and also some severe risks of toxicity in terms of permanent deafness and renal dysfunction and electrolyte imbalances. So those three side effects really weighed on the side of looking critically of what is the role of the injectables, and if they're not associated with a higher efficacy of treatment, should we be prioritizing them in our MDRTB regimens? So I want to share some evidence that we got from the NTB observational study. NTB is a big project sponsored by Unitaid. It has 2 randomized controlled trials in it. We are not going to discuss those results because those trials are ongoing, but it also had a large observational study as part of the project, and we were able to analyze 1,120 patients, MDRTB patients treated in 16 different countries. And we thought it would be interesting to ask this very unique question that I don't think people have asked. And this study has been published. I'll show you some of the results on the next slides. But the question we asked was, among individuals receiving a bedaquiline and or delamitid containing regimen, do injectable containing regimens offer greater effectiveness than all oral regimens? That hasn't been looked at. So basically what we're asking is, the regimens contain now new TB drugs. Do we still need the injectable with the new TB drugs? Do they add anything? And here you'll see in the European Respiratory Journal, we have published a study that shows that all oral longer regimens are effective for managing multidrug-resistant tuberculosis. But really this study, what we did in this study is compare people that got the all oral regimens, which contain the new drugs like bedaquiline, delamitid, linezolid, clofazimine, and 2 patients that got an injectable-based regimen. And what an injectable-based regimen that also included those new TB drugs like bedaquiline, delamitid, linezolid, and clofazimine. And what we saw was that the culture conversion was the same, essentially the same. It was in the all oral regimens, it was 83.8%, and this was not statistically different from the people that got the injectable containing regimens. It was slightly higher, but not statistically significant. Essentially, they're the same number. The number with the injectable was 85.5. So that is no difference. But we do know that there's considerable toxicity in those patients that got the injectable agent. And you can get the same cure rates without the toxicity. That is a good thing. And therefore, we agree with the conclusion of the WHO that we can deprioritize the injectable agents, making them less of a priority when we design regimens. And if you know the new grouping of the drugs, we'll see in the next slide, sorry, we'll see that the new grouping of drugs used to treat drug-resistant TB, they really put low down the injectable agents such as amikacin and streptomycin. And their evidence has actually shown that kanamycin and capreomycin were negatively associated with success in a meta-analysis that the WHO did for the guidelines. And we therefore agree with this new grouping of the drugs and putting the injectable so low in the hierarchy and keeping just amikacin in the group C drugs. And there are some rare instances where you may prefer streptomycin over amikacin. We will not go into that, but that would be essentially that you're resistant to amikacin and resistant to so many of the group A drugs and B drugs that you have to use an injectable. And the only one available is streptomycin because amikacin is resistant. And so what's interesting about this new hierarchy of drugs, and you may have asked this to yourself, is what are the treatment outcomes if we use this hierarchy of drugs to design the regimens based on it? And are we getting better outcomes if we design regimens based on this new hierarchy, group A drugs, and to try to include all three group A drugs when possible, add one or both group B drugs, and then add group C drugs as needed? What are the outcomes for that? And can most people get all oral regimens? Let me just pause here for a minute. So we did a sub-analysis in this NTB observational study. So one of the sub-analysis I just showed you was, did people do better on the injectable or not? The next sub-analysis we did, which not yet published, and the data is still preliminary, we looked at if you had exactly 3 group A drugs, how did you do? If you had exactly 2 group A drugs, how did you do? If you had exactly 1 group A drug, how did you do? To see how people did in all oral regimens. And I'm only sharing with you the preliminary data, which I find is quite interesting. But the patients who received influoquine susceptible MDRTB, patients that received exactly 3 group A drugs, plus at least 1 group B drug, plus or minus group C drugs. So they had at least 4 effective drugs, and they had exactly 3 and at least 1 group B drug. Some of them only had 4 drugs. Some of them might have had extra C drugs added. Their success rate varied from 75 to 85% success rate. That's pretty good. So if you use all 3 group A drugs and use that new hierarchy of drugs and have an all oral regimen, this was done across, again, 16 countries and about 800 patients. No, only about 400 or 500 patients got the exactly 3 group A drugs. So it's on a pretty large cohort that got the 3 group A drugs, and we see that they did pretty well. So this indicates to me that for fluoroquine susceptible MDRTB, if you can use the 3 group A drugs, it seems like a good idea. And it seems like you can have everyone in fluoroquine susceptible MDRTB on an all oral regimen pretty easily and have 4 effective drugs. Again, this is outcomes from all oral regimens. Interestingly, in fluoroquine resistant MDRTB, patients that received exactly 2 group A drugs, now the group A drug of the fluoroquinolone, levofloxacin or moxifloxacin, would be considered resistant. So these are patients that got exactly 2 group A drugs. That would have been bedaquiline and linezolid. And they did about the same. And you would use at least 1 group B drug and plus or minus some group C drugs to get at least 4 effective drugs. All those patients did pretty much the same as the fluoroquine susceptible. This is the first time, I think, in the history of TB treatment that fluoroquine resistant regimens are doing almost as well as the fluoroquine susceptible regimens. This I find also encouraging that the new grouping of TB drugs are possible, and these again are all oral regimens for fluoroquine-resistant. In the fluoroquine-resistant MDR-TB patients that received exactly one group A drug and had an all-oral regimen, their outcomes were a little bit worse than if you got exactly 3 or exactly 2. This makes sense, and it supports the idea that the group A drugs, as listed, are the most powerful drugs in the regimen. So if you can only use one in your all-oral regimen, you may be getting worse outcomes. We have to do a lot more analysis on this to see which combinations of drugs had the best effectiveness, and we're doing that analysis, and I look forward to sharing that to the group when it comes out. But the conclusion here is that WHO conforming individualized longer all-oral regimens that contain group A drugs do appear effective. And the more group A drugs you have, the better it likely is. And I think this strongly supports, combined with the other data that I shared with you, that there's really very little role for the injectables going forward. And this is hugely good news for the patients because they will not suffer hearing loss. They will not suffer renal failure or severe electrolyte disturbances and possibly death from those electrolyte disturbances, especially using QT prolonging drugs. So all of this is excellent news, and really in your programs, it should be the rare patient that you have to use the injectable going forward. I have one last slide I want to share with you. And this is just to review the dosing adjustments in people with renal insufficiency. And we really mostly only dose adjust when the creatinine clearance is less than 30 milliliters per minute. That's considered, when it's less than 30, it's considered severe renal insufficiency. And unless it's otherwise noted how to adjust it on the chart here, there's some different adjustments based on 40 cutoff versus 20 cutoff indicated in the chart. And there's a few new drugs on here that you may not be familiar with in adjusting for renal insufficiency. And I'm just gonna maybe say a comment on them. I think the quinolones are well known how to adjust those, and moxifloxacin doesn't need any adjustment. If you're using high dose moxifloxacin, it's the same thing. You don't need to adjust it. It's not metabolized by the kidneys. Bedaquiline, we don't change it for mild to moderate renal insufficiency, but unfortunately, there's not much information in severe renal insufficiency. So people and there's also not much information on people who are on hemodialysis or peritoneal dialysis on how to monitor that. When drug level monitoring becomes more available, I don't think many countries have that for bedaquiline. That may be something we want to do in severe renal insufficiency. Right now, I think if you have a patient with renal insufficiency that is severe, you could probably use it with caution and explain to the patient the unknown risks of using it. But if you have no other choice, I don't think you should automatically not use bedaquiline in severe renal insufficiency. Just explain the risks and that the unknown nature of using it in patients, but the benefit of getting bedaquiline may outweigh those risks. Linezolid is, there's essentially no change needed. There may be some metabolites of linezolid that accumulate, but these are known not to be toxic to the body. So we really don't worry about that. And we do use it in severe renal failure without adjustment, but some caution and explanation to the patient that there could be, unknown effects that we don't know about yet, and just monitor the patient for increased toxicity in terms of their myelosuppression and peripheral neuropathy, but we don't think it increases those things in severe renal failure. Delamanid, I'll say it also does not need any dose adjustment in mild to moderate insufficiency. However, we don't have much experience for it, and so it is generally not recommended for patients with severe renal insufficiency. If it moves up in the hierarchy of drugs, we may want to consider it like bedaquiline, like the benefits might outweigh the unknown risks, and patients may want to accept those risks and take it if there's no other options. But usually there's other options other than Delamanid. So I'll leave it at that. Okay, I'm gonna move to the end of the lecture and just let you all know again that my email is there, and I hope there's a lively discussion on some of the issues and evidence that I presented. And I hope to see you all soon, either virtually again, live, or one day in person, I hope, again. Thank you very much.
Спасибо большое.
Thank you very much, dear Michael, for such an interesting presentation and for such a good introduction to our next speaker, to our next presentation, which will be delivered by Dr. Berikova, who is an expert of our Virtual Consilium from Kazakhstan. Dr. Berikova will speak in detail about the management of multidrug-resistant TB with renal failure.
Hello, dear colleagues. I'm glad to see you all. Happy forthcoming New Year to all of you. As Michael has already said, we often see some adverse reactions in the treatment of patients with drug-resistant tuberculosis. And on this slide, you can see the data of Sergei Borisov from his study, which shows the frequency and type of adverse events. And if we talk about the effects on kidneys, you will see that it was reported in more than 1%. And usually the injectable drugs caused those reactions, and pyrazinamide. On this slide, you can see the list of drugs that usually cause adverse events. And here you can see the linezolid, PAS, and injectable drugs, which in more than 10% of cases cause various adverse events. And as Michael has mentioned, amikacin causes, or other injectable drugs, have renal toxicity, disturbances of electrolyte disturbances, and we switch more and more to fully oral treatment regimens, and we're able to reduce a number of adverse reactions in treatment of drug-resistant tuberculosis. So what is nephrotoxicity? Nephrotoxicity is a capacity of chemicals to cause structural and functional kidney damage through a non-mechanical action on the body. Nephrotoxicity can be manifested as a result of direct action on chemicals on the renal parenchyma, and indirect action through changes in hemodynamics, acid-base equilibrium of the internal environment. these drugs are usually can be excreted through kidneys. Nephrotoxic are substances that have direct effect on kidneys. And of course, we need to remember about high sensitivity of kidney tissue, high intensity of renal blood flow, and the ability to concentrate xenobiotics during urine formation, reabsorption of some excreted xenobiotics into the cells of renal tubule epithelium, and it is determined by a transformation of xenobiotics. There is a number of risk factors that can lead to the development of renal failures. And of course, if patients do not have those risk factors, nephrotoxicity will be less frequently manifested. So these risk factors include absolute or effective blood volume deficiency. We talk about absolute deficiency when patients lose fluids due to diarrhea or due to the use of some drugs. Or when patients have ascites and heart failure, when fluids remain in the human body. Among other risk factors, we also note age over 60 years, diabetes, HIV, and simultaneous exposure to more than one nephrotoxins. Also, heart failure, sepsis, and renal failure in the history of our patients. And GFR at the level of less than 60 milliliters per minute. As for nephrotoxic effect of aminoglycosides, such as adenavir, tenofovir, and so on, the duration, among risk factors, we see the baseline renal failure and treatment duration of more than 10 days, minimum concentration of more than 2 micrograms per milliliter, and the history of concomitant liver disease and HIV. Renal tubule cells, especially renal proximal tubule cells, are sensitive to the toxic effects of drugs because they are involved in the processes of reabsorption of glomerular filtrate and urine concentration. Clinically, patients may have such complaints as nausea, vomiting, dehydration, dyspepsia, diarrhea, oliguria, anuria, polyuria, peripheral edema. The patients may have some allergic reactions, including to Lyle's syndrome, pain in the lumbar region, renal colic, and acute uric acid nephropathy and hematuria. When we look at the CBC results, we can see eosinophilia, leukocytosis, leukopenia, thrombocytopenia, and increased sedimentation rate, as well as anemia. As for the urine tests, we can see proteinuria from moderate to severe, and cylindruria. As for the blood chemistry, we can see hypercreatine anemia, decreased GFR, electrolyte disorders, when we look at ECG, we can see disorders of rhythm and cardiac conduction, and chest X-rays usually showed fluid accumulation in pleural cavities and pulmonary edema. Ultrasound of kidneys and abdomen show increased volume of kidneys and presence of concrements in the renal pelvis or urinary tract. Speaking of manifestations of nephrotoxic effects, we can mention blood in urine, protein in urine in the amount of more than 0.5 grams per daily sample. We can also report decrease in the amount of excreted urine and increased plasma contact of nitrogen containing low molecular weight. And of course, hypertension as the results of glomerulosclerosis. The main syndromes of nephrotoxicity include acute renal failure manifested by azotemia and oliguria, chronic renal failure, tubular intestinal nephritis, acute or chronic, with some signs of tubular dysfunction, and rapidly progressing glomerulonephritis manifested by hematuria and oliguria. On the slide, you can see the normal values of creatinine and creatinine clearance. And based on this information, we can make the diagnosis of renal failure. In men, it is up to 115, and in women, creatinine is up to 97, from 53 to 97. So what needs to be done in order to prevent the drug-induced nephrotoxicity? We need to adjust medication doses used for treatment of the diseases using the Cockcroft Gold formula or Schwartz formula for children. We also need to perform the assessment of pre-treatment renal function with patients with MDRTB formula. And we also need to check renal function prior to prescribing new medication. We need to avoid combinations of nephrotoxic drugs and correct nephrotoxicity risk factors before treatment initiation. We also need to provide adequate hydration before and during treatment and prescribe drugs with similar effects that are not nephrotoxic. You can see formulas for renal function assessment to adjust medication doses on this slide. And so we need to know clearance of creatinine. We have different numbers for men and for women in order to perform proper calculations. Here, you can also see modification of diet in renal diseases and Schwartz formula for calculations in children. So how do we monitor nephrotoxicity? We need to repeat clinical urine tests for abnormal urine sediment findings. We see whether in urine samples there is protein, and that would be the sign of the development of nephrotoxicity. Every 3 days, we need to control blood plasma creatinine level, blood plasma urea level, and calculate GFR. If GFR decreased by 50% or more, it is important to discontinue the injectable drug or to consider another drug that could be used instead of the injectable drug. It is also wise to consider intermittent use of injectable drug or reduction of the dose. On this slide, you can see the protocol data that we used in the framework of the operational study. This is the laboratory monitoring of adverse events. Here you see requirements for CBC or urinalysis, liver function tests, and serum creatinine and GFR. You can see that these recommendations require monthly monitoring. Serum potassium and serum creatinine should also be monitored monthly. And what are the main therapeutic principles? It should be noted that most drugs that are excreted through kidneys do not require dose adjustment until clearance creatinine drops below 50 milliliters per minute. Adequate hydration is very important to maintain renal perfusion and to avoid drug-induced damage to the renal tissue. Before treatment initiation, if you plan to use nephrotoxic drugs, it is important to assess blood volume. And severe blood volume deficit is manifested by orthostatic hypertension, blood pressure below 90/60, and decreased skin turgor and loss of more than 5% of initial pretreatment body weight. In general, drug-induced renal damage is manageable, but it should be done on time. Changes in serum creatinine level, that is an increase by 50% of the initial level or by more than 0.04 millimole with the initial values less than 0.180 millimoles per liter is a biochemical criteria for ARF. Speaking of management strategy, it should be noted that all first signs of renal failure, the exposure to causative factors should be stopped immediately, if possible, or its effect should be minimized. During treatment, special attention should be paid to maintaining water electrolyte homeostasis, blood acid-base balance, and blood pressure. It is also possible to use crystalloid isoosmol solutions. Sodium bicarbonate solution and antihypertensive drugs. Conservative treatment is aimed at etiological, pathogenetic, and symptomatic aspects. On this slide, you can see management strategy. If you're interested, you can study this information in more details when you have the presentation in hand. And here you can see that bed rest is recommended for the first 24 hours. Patients should also stick to proper diet, and it should also be noted that the use of glucocortic steroids in the treatment of renal failure has failed to show efficacy in restoring renal function, and therefore it is not recommended in most cases. GCS is recommended when renal function does not improve after cessation of the causative factors. There is no need for additional intervention in patients with minimal alleviation of blood creatinine or recovery of renal function within 3 to 7 days. As for GCS therapy, prednisolone is recommended for a minimum 1 to 2 weeks. Starting dose is increasing when creatinine returns to near basal levels. And the full duration of treatment is from 2 to 3 months. What are the indications for renal replacement therapy? They include 58% renal output of about 20 milliliters per 20 hours, hypokalemia at the level of 6.5 millimole per liter, and no deep tendon reflexes, acidosis less than 7.15, and refractory edema. Renal replacement therapy methods in acute renal injury are subdivided into extracorporeal and intracorporeal. Intermittent methods are performed daily for 2 to 4 hours. They include hemodialysis, hemofiltrations, and hemodiafiltration. Continuous methods can also be used almost around the clock for several days or even weeks. In conclusion, I would like to say that treatment of MDRTB is a major challenge because of the long duration of therapy, high cost, and adverse events associated with the complex treatment regimens. Adverse events are more common with MDRTB treatment compared to the standard treatment of drug-susceptible TB, which can lead to poor patients' adherence and unfavorable treatment outcomes. Therefore, close monitoring and proper management of MDR-TB patients to prevent unfavorable outcomes and amplification of drug resistance is important. Regarding nephrotoxicity, gradual switch to all oral or scaling up of all oral treatment regimens for MDR-TB will significantly reduce the incidence of this adverse event. Overall, reducing the duration of DRTB treatment with transition to shorter treatment regimens will improve treatment tolerance and adherence to treatment. Thank you for your attention. Thank you very much, Dr. Berikova, for this excellent, detailed, and concise presentation. You were able to present all the necessary information on this very complex topic. Thank you very much. Everything was clear, and I'm sure that our dear colleagues, clinicians, will get back to this presentation in their practice. And I would like to remind all of you once again that right now you can download all presentations of our meeting if you follow the link in the chat. Thank you very much. I see there are some questions and I would like to ask them during our Q&A session. And now I would like to invite our last speaker for today, Dr. Natalya Yatskevich from the National Research Center in Belarus, who is one of the key researchers in the operational study in Belarus, and she will talk about management of MDR rifampicin-resistant TB patients with renal failure. Dear colleagues, good afternoon. Thank you very much for an opportunity to share the experience of Belarus in management of MDRTB patients with renal failure in the framework of modified shorter treatment regimens. The indication of drugs or designing of treatment regimens should be done in due consideration of adverse events of special interests or aggravation of comorbidities. Of course, during treatment, we need to ensure proper monitoring and timely adjust treatment when necessary. Michael already told us about the correction of doses, which should be done in case of renal insufficiency. I will not go in all the details of this slide, but I would like to say that when we use fluoroquinolones, we should say that fluoroquinolones have an excellent safety profile. However, when fluoroquinolone can cause some adverse reactions, and these adverse reactions can include tendon rupture, peripheral neuropathy. They can also have the risk of aortic aneurysm and dissection, especially in older patients. The reasons for that have not been identified yet. Also, the use of fluoroquinolones can cause the development of diarrhea associated with Clostridium difficile. I mentioned the tendon rupture. It can happen within the first days or during the first months of discontinuation of levofloxacin in patients who are older than 60 years of age, or patients who have a lot of physical activities or renal failure. Adverse reactions can be irreversible. They may give tickling effect, burning effect, and other changes in sensation. They can also cause QT interval prolongation. Cycloserine is also associated with some adverse reactions, which include effects on central nervous system, peripheral neuropathy, hallucinations, nightmares, depression, anxiety, psychiatric disorders, and in such cases, cycloserine should be discontinued immediately. Cycloserine can also cause rashes, peripheral neuropathy, jaundice, and visual impairment. Cycloserine should not be given to patients with epilepsy, severe depression or psychosis, severe renal impairment, or severe alcohol abuse. An increase of concentration of cycloserine in blood can cause some additional side effects. And here I would like to present a clinical case. This is a man, 69 years of age. He was hospitalized at the municipal hospital with complaints of short breath and pain in chest. X-ray showed some abnormalities in chest. DNA of MTB complex were identified, and patients was transferred to the research center where the diagnosis of infiltrative TB was made. The patient started using treatment, and that patient had negative hepatitis and HIV tests, and microscopy gave negative results, and no history of contacts with TB patients was reported. Before treatment, we got the following results. Creatine at the level of 118, eGFR 53.8, severity grade 2. We also got the results of bacteriological examinations. These are LP results, and we could see a resistance to isoniazid and rifampicin, while that patient was susceptible to fluoroquinolones. We got informed consent from the patients and enrolled this patient into the operational study. So that patient had the diagnosis of infiltrative pulmonary tuberculosis with resistance to rifampicin. As for comorbidities, that patient had ischemic heart disease, atherosclerotic cardiosclerosis, sinus bradycardia, atherosclerosis of aorta and coronary arteries, insufficiency of the aortic valve with grade 1 regurgitation. That patient was consulted by the nephrologist and cardiologist, and during the course of treatment, we ensured regular monitoring of patient's condition. During treatment, we checked biochemical blood tests and could see a drop in eGFR, and we also identified some drop in the level of hemoglobin and platelets, which could be associated with the use of linezolid. That patient was treated with the first-line drugs, received pyridoxine, folic acid, rivaroxaban and antihypertensive therapy. Prior to treatment initiation, we performed ultrasound examination of kidneys, except for the cyst, no other abnormalities were detected. Since the levels of creatinine were alleviated and due to the results of eGFR, we had to adjust treatment. We used the following drugs with close monitoring, not just once a month, but once a week. This patient or this case was presented at the International Consilium, and during the course of treatment, we reported a drop in the level of GFR, and it was recommended to adjust patient treatment, the dose of lexafloxacin and cycloserine, and to continue monitoring of kidney function. And to get back to the usual dose of cycloserine if eGFR is at the level of about 30. And if it is over 50, levofloxacin can be reinitiated based on patient's body weight. In case of thrombocytopenia, the dose of linezolid is to be adjusted to 300 milligrams a day, but we didn't have to do it. Concomitant pathologies required very close monitoring of the use of drugs, not just TB drugs, but other drugs as well. We also needed to engage a cardiologist for counseling. We implemented cardiography at the beginning of treatment and during treatment.
Because of the concomitant diseases, we performed correcting therapy because of the varicosis of the lower extremities. And treatment was performed based on the D-dimers and coagulogram. We switched to rivaroxaban, and we also performed hypertensive therapy. He received hypertensive drugs, and one of the blood tests revealed creatinine level reduction, increase of glomerular filtration rate above 50, and based on the decision of the physician's panel, we adjusted the dose of afloxacin, performed monitoring, and we saw that the function of kidneys was diminished, and therefore we switched to intermittent use of levofloxacin. The person was discharged to outpatient treatment, and the treatment was successful. We performed regular treatment monitoring, and we have not seen glomerular filtration rate dropping below 30. We seen a slight elevation of AST above the norm. Hemoglobin platelets didn't fall, and speaking about causality, we can see some association between the renal insufficiency and levofloxacin and cycloserine. We can believe that there is positive association, and causality is positive because the challenge and reduced dosage improved renal function. And when we reinstitute the dose, the function slightly diminished. The Xray revealed regression of infiltrative changes in the lung. The patient was treated for 9 months, received all the doses, successfully completed treatment. We reached sputum negativation and positive Xray dynamics, and On the 1st of July, the person completed treatment. We also performed post-treatment monitoring, and no significant changes were detected. Creatinine 3 months after treatment was 130.5 micromils per liter. EGFR was 47.7, and the second degree of severity, but the function of kidneys was preserved. Thank you for your attention. That is our case. Thank you, Natalya, for such an interesting case presentation. I would like to mention that this case confirms how important it is to not only perform tests mechanically according to the schedule, but to use the findings to correct and adjust treatment regimen in a timely manner. Despite a plethora of concomitant diseases, the person was kept on treatment, completed the treatment, and was cured. Thank you very much for your experience. Thank you for mentioning the role of Virtual Medical Consilium. I remember the presentation of this particular case, and I also would like to remind all the audience to use the support of the Virtual Medical Consilium if you face difficult cases, not only within operational research, but even in your daily routine work. If you have difficulties in using new drugs, please seek care of our Virtual Medical Consilium. I think that we can switch to Q&A session. I would like to read up the question from Dr. Aslanova. Hello. Could you please tell us about the management of drug-resistant cases following kidney transplant? What are the principles or what the risks? Maybe Dr. Berikova, you will answer this question. Thank you for this question. It's issue how to manage patients following kidney transplant, especially if they have TB. As we presented in our slides, we need to that these drugs do not affect kidney function, and these drugs do not need dose adjustment in renal insufficiency. There is sufficient number of drugs not affecting moxifloxacin, linezolid, bedaquiline, clofazimine, and ethianamide and protonamide. These drugs do not affect kidney function. They don't have nephrotoxic effect. Just speaking, using my experience, I would like to say that it's better to stick to shorter treatment regimen, but you will need to adjust the dose of levofloxacin. The rest of the drugs are safe, but every 3 days you need to perform kidney function, EGFR, creatinine clearance, and the creatinine level itself, and urea level. And based on the changes of the creatinine clearance, you should adjust the doses. Perhaps you will need to switch to intermittent use of drugs. Thank you, Dr. Berikova. I said if you have some additional questions or clarifications, please jot them down. I don't see any additional questions so far. I would like to remind all of you that if you have questions about our first presentation, if you have questions to Dr. Michel Rich, you can either send them directly to him using his email or put them down in the chat, and we will forward all of them to Dr. Rich. I see a hand raised. Could you please ask the question? Please unmute yourself. The person who raised the hand. So if someone wants to ask a question, I see a chat. What drugs can you offer for patients on dialysis? Dr. Berikova, perhaps that's one more question to you. Thank you. I was limited in time. we can present a patient on hemodialysis. Patients who receive hemodialysis, we have had such patients and we still have them on treatment. They received the drugs I have already mentioned, moxifloxacin, clofazimine, linezolid, but one need to look. We prescribe one treatment regimen based on the drugs not implicated in nephrotoxicity, and we monitor closely treatment regimen, and we either reduce the dosage of drugs or we switch to intermittent use. But based on our practice, patients we have on hemodialysis, they were able, with chronic kidney disease, they were able to receive the drugs with a high level of creatinine above 1,000, 1,500, 2,000 on hemodialysis. They at least three on bedaquiline, linezolid, moxifloxacin, or levofloxacin, and they were not able to tolerate other drugs. And we are speaking about very severe cases on hemodialysis. The next question from Natalya Stavitska. What about cytostatics following transplant in TB and acute kidney failure? If patients don't have TB, we perform preventive treatment. Patients on cytostatics should receive preventive treatment, isoniazid, with the adjusted dose we have presented, the dose adjustment approach. There is a table you can follow to adjust the isoniazid dose, but if the disease develops, then the approach will be the same as in patients with renal insufficiency, correcting and adjusting doses and choosing the drugs without nephrotoxicity. Thank you. Usually kidney transplantation is an elective procedure prior to which people are usually tested for latent TB infection. And as Dr. Berikova has mentioned, in case of latent TB infection, preventive TB treatment is performed. If a person is diagnosed with active TB, it's usually recommended to complete the course of treatment and then proceed with kidney transplantation. Because it's a rare case that surgeons will take a person with active TB. Erythropoietin in myelosuppression on the background of linezolid and renal insufficiency. What are the pros and cons? Dr. Berikova, one more question to you. In this particular case, I won't be able to answer that because we don't use erythropoietin and we have not used it. Maybe there are people who use it in their practice. I'm unfortunately unable to answer this. I will look for raised hands. Elmira, this question might be addressed to Dr. Rich. We will translate it into English. And maybe he will present a review to answer this question. I can prepare literature analysis, but unfortunately, we don't have practical experience. I don't see any raised hands, and we are approaching the end of today's webinar. I would like to thank everyone. I would like to thank all the experts and the secretariat for the opportunity to deliver such a webinar. I would like to thank the audience for ongoing interest. We always have more than 100 participants. We have constant participants based on the list of participants. Thank you very much for your questions, for your interest. Thank you for seeking support of the medical consilium. Thank you for presenting cases. Despite the approaching holiday seasons, we'll be on duty. We will be waiting for your questions and we will try to come up with answers within 48 hours. Let me please use this opportunity to congratulate everyone on approaching holidays, New Year, Christmas, and I would like to wish all of you everything the best, good health. We'll be looking forward to our next meeting next year, and I would like to pass the mic to Dr. Yedilbayev for his final words. Thank you very much, Elmira. Dear colleagues, let me, on behalf of the WHO Europe, to thank you for your interest, for your participation. We hope that this virtual consilium is a useful tool in your work.
Хотел бы повторить слова Эльмиры о том, что мы...
Once again, I wanted to repeat Elmira's words. We always welcome your cases because it is a good sign for us to see the cases, and if we see less and less cases presented, it means that we have less and less cases and result. However, we plan to continue this work next year and in the future, and in addition to expert reviews, we also plan to have monthly webinars. We plan to cover more countries, and we also plan to have country-specific webinars. We will discuss it in more details, and we will discuss it with the representatives of the national TB control programs. Next year will be very important because we expect to see updated guidelines of the WHO on treatment of drug-resistant tuberculosis in February and March of 2022. The guideline development group on drug-resistant tuberculosis will discuss and highlight issues related to an update on the use of bedaquiline and the lamanid. Also, it should be noted that these plans are for the next year, but we'll keep you posted and we'll share the most recent information with you, and hopefully it will be useful for you. Next year, we will expect the publication of the WHO guidelines on treatment of drug-resistant tuberculosis in children. Once again, thank you very much for your attention, participation. We are wishing you peace, health, understanding, and warmth. Thank you very much for your hard work, and happy forthcoming new year.
Всего хорошего. До свидания, дорогие коллеги.